I can make a co-host, or I might need you to do that, Elizabeth, for me, making him co-host. Awesome, thank you.
Oh, thank goodness. I was just saying a bunch of stupid things, but I was muted. That was great. Can everybody hear me okay?
Yeah, we can hear you.
Okay, great. So I'm gonna try not to do a ton of lengthy talking, but I'll talk until Jen shows up again. Till Jennifer shows up again or something. So I think that's all we're doing today is Jennifer and me. And so I am talking about things that you can get from Oxoides ticks besides Lyme, which is a surprisingly high number of other microbes. So, and please, as usual, interrupt, ask questions. I want y'all to get something out of the talk, fill in blanks in your knowledge, or ask me to clarify anything which might be terrible on the PowerPoints, because the PowerPoints were being made last night, and I was forced to go see a movie called Barbie, and it was Kaylee's fault. She made me go see it. It's very good.
A great movie.
It was a great movie. It was, you know what? It was much more entertaining than making a PowerPoint. And so, anyway, so you got a hodgepodge Frankenstein type PowerPoint I put together. But it's a topic I'm passionate about. I would rather just talk about it than do a PowerPoint. But I'm going to show you these things anyway. So anyway, let's talk a little bit about this is a fun slide, because I feel like ticks get a bad name, and it's because of the country we live in. Ticks are like enemy number one in the United States, but we need to feel good about where we live and be a little happy. So these are the arthropods worldwide we would have to worry about if we lived elsewhere. So there's ticks, lice, mosquitoes. Oops, I reversed that. Sorry. Ticks, fleas, mosquitoes, lice, mites, flies, and bugs. Like those are all actual real things. And each one of them can carry a lot of different diseases. Actually, one of the reasons I went into infectious diseases is because I love bugs and animals, and I got to learn about pathogens that each carry. We're a little blessed in the US because we don't have a lot of pathogens from much besides ticks and mosquitoes, and even our mosquitoes are relatively friendly with what they carry. So we're lucky. Ticks are probably the arthropods that carry the most of anything, and you can see they can carry funny pathogens like rickettsia, which, remember, those funny intracellular mitochondrial wannabes that act as pathogens. They can carry the spirochetes that we all know and dislike because of our recollection of Lyme. But just remember, there's a bunch of other spirochetes that ticks can carry as well that do unusual stuff. Other rash illnesses, other relapsing fevers, and other oddities. There's actually some malaria mimics, so some protozoans that ticks carry. Plague-like bacteria known as tularemia can come from ticks. It's not the only place it comes from, but that's one of the places it can come from. And then even viruses. And this list of viruses is sort of ever expanding. And you can see all the weird names up there: Bourbon, Heartland, Colorado, Powassan. Just know there's viruses too that ticks can carry, and then even non-infectious things like tick paralysis. Talk about a fascinating disease process, not an infection. It's just a toxin-mediated process. And then there's the alpha-gal, which is an acquired allergy to mammal meat. Mammal meat being a fun word to say, by the way, but it's an acquired allergy to mammal meat and milk. Mammal meat and milk. There we go. Now, ticks suck blood. Ticks are bad. That's what they do. They suck blood. There's a misnomer that they are more predatory than they are. They can't chase you, can't fly. They don't jump out of trees onto your head. They sit on the end of vegetation stalks or in leaf litter and sort of slowly crawl onto you. They do sleep in the wintertime. The problem is we don't have a winter time anymore in the mid-Atlantic. And so we'd see tick-borne illnesses all the way through January. All you need is a 45-degree day. So a couple of 45 degrees days and you can have tick-borne illnesses. It's funny, when you look at old textbooks, they basically say, November through April, you're good. You don't have to worry too much about it in our area. And then that's no longer really true. It's just we have ticks all the time. Ticks can spread disease from their saliva. Ticks can spread disease from their feces. Pleasant thought. So either or. Most of the things we talk about, I'm going to talk, actually all of the things I talk about today from the Axoides ticks are from their saliva. Okay. And how do ticks actually become infected or carriers of these pathogens? They can acquire it from an animal they feed on. And so they, will feed on a white-footed deer mouse or a deer or a bird or something else and acquire whatever that pathogen is from a bacteriemic animal. They can actually get it from a prior stage of their development. They can get it, they can be born with it, or actually they can acquire it as an STD. So I put that picture up there to haunt your all's brains of those two ticks engaged in intercourse. And just know that we should probably be talking about doxy prep for tick STDs too. Bad joke there, but this is the right group to have that joke with. This is probably one of the most important slides, and that's that exposure history is key. And one of the cases I'll share with you guys really speaks to the importance of an exposure history. Usually your threshold to think of a tick-borne illness comes with how detailed you are in pursuing a good exposure history. And remember that these diseases, there's absolutely nothing about the non-Lyme pathogens that ever tell you that they are what they are. That was horribly worded, but what I mean is Lyme disease tells you what it is. It gives you a bullseye rash, it gives you facial paralysis, it gives you a swollen knee, it gives you a heart block. None of the other co-infections give you anything specific. They look identical to everything else that gives you a fever, a sourceless fever. So they look like COVID. They look like the summer flu. They look like sepsis. They look like pyelonephritis without back pain. They really, there's nothing on clinical history that's going to make you say, holy crap, this person has a tick-borne illness. They're just going to present with fevers, aches, and I don't feel good and I don't know why. And test me for COVID, please, or the flu or something else. And until you get possible exposure to the great outdoors or, possible furry friends or some other activity that might put them at risk of tick exposure, you probably aren't going to think about these very much. At least I know I don't. But then when I hear that they have furry friends or engaged in outdoor activities routinely, you have to enter that concept. What is absent from exposure history in the majority of tick-borne diseases is a tick bite. That's a wickedly frustrating statement, but it's the almost majority or super majority that do not recollect a tick bite or pulling a tick off of them. These are too small, especially the Axoides. So you seldom actually get that as your history. In fact, most of the time, I see confirmed in exposure history, the patient has no known tick bite. And clearly it's the known part that matters. There are all these like urgent warnings that have been out over the past 2 years from the CDC and from various state health departments, very appropriately saying, like Eminem says, don't forget about me. Don't forget about tick-borne illnesses. I have no idea what that meant. Something was playing through my head. I think there's an analogy in there. Don't forget about tick-borne illnesses. Not everything is COVID. Yes, COVID's a thing. Yes, febrile illnesses. We should think about COVID. But if our COVID test is negative, before you just say, well, I don't know what you got, say maybe you have a tick-borne illness and test for it, think about it, and go from there. When you do talk about tick-borne illness, remember there are various time factors we talk about. One of them I never want you to memorize. Know that each entity, each organism has its own incubation period. So that's a characteristic or trait of each organism, and it's not worth memorizing. And there's also a range for each one. But most of them are somewhere around a week as a really bad rule of thumb, but they can be longer, they can be shorter. They don't tend to be a year down the road, and they don't tend to be within hours. And so, but there is an incubation period. As I mentioned before, time of the year really, I don't think plays as big a role as the textbooks will tell you, because we have ticks all year long now. The other time factor that does matter a little bit is attachment time. It's really, really, really hard to estimate. That's why I said question mark clinical utility. I'm dead wrong very often on whether or not a tick is engorged or not. So I might look at a tick, especially a small Ixodes nymph, and think it's not engorged. And then under a microscope, the pathologist might be like, yeah, man, that was engorged for like, that had about 72 hours worth of blood, or that had, 5 days worth of blood in it. And I was like, wrong. So it's really hard for the Ixodes to estimate that. One of the things we preach during our Lyme lectures is that if you do have a tick that's been attached for less than 36 hours, there's no risk of transmission of the Lyme pathogen. And that's true for Lyme. It really takes a little bit of time for it to transmit that stuff. But, for some of the other co-transmission microbes, transmission can occur almost at the time of bite. So Anaplasma, Babesia, a couple of other ones I'll talk about really transmit really, really quickly. And so just taking the tick off that's embedded but not engorged is not necessarily comforting for non-Lyme pathogens. I hope that made sense. Okay, so when you do have a patient pull a tick off, if they bring it in and you're not sure what it is, feel free to hit Google. Honestly, that's what I do, because I can't remember what these things look like. But no, what are the major 3 tick species that we have in West Virginia? The dog tick, the deer tick, and the Lone Star tick. And only the grown-up female Lone Star tick has the really telltale star, the dot in its back. The other ones you sort of have to look up just to match for color. The nice thing is they sort of have, either orangish or brownish or some characteristic shell pattern, depending on if it's a boy or a girl and the stage that they're in. But those are the 3 major ones that you'd want to look up and match. Today, we're going to talk. Oh, and one more thing. If you do have the tick, and you have a patient that has somewhere between $49 and $99 to spend, and the patient really wants to know what type of tick it is, how long it was attached, and wants an incredibly extensive pattern or a description of what pathogens were in the tick, you can send it off to one of these commercial laboratories like tickcheck.com. They can test for so many more pathogens in the ticks than we can in a human. And they do it via PCR. Now, I will say that the professional societies that tell me what to tell you encourage that I not tell patients to use this, because it's costly, number one, and sometimes you'll get a tick with weird stuff in it and it'll freak the patient out. So you just realize that just because a tick may have a certain pathogen in it does not necessarily necessitate transmission to the human. And so it requires a bit of thought and a bit of caution. Why do I like this service? I like this service because it's about the only way I really get to know what pathogens are floating around in the environment. There literally are things that they can test for much more easily in the tick than I can in the patient. So anyway, I always try to sell my patients on this if they have extra money and they save the tick. So the Ixodes scapularis, this is our deer tick. This is our tiny unwelcomed friend, and it is the transmission arthropod of Lyme. And so everybody remembers that deer tick and Lyme disease, the Borrelia burgdorferi, but it carries a lot of other stuff too. It carries 3 or 4 other diseases, maybe more commonly. So there are other spirochetes that it can transmit. I don't think the first one matters. This one's named after the Mayo Clinic. And really, this is another cause of Lyme disease. So really clinically, nothing you need to know differently here. This one right here with the interesting name that sounds Japanese was in fact first recognized in Japan. And it causes an unusual form of relapsing fever, where the clinical history is somebody has a febrile illness that lasts a few days, resolves, has a few days of fever-free without therapy, and then comes back, and then may have 3 or 4 of those episodes over the course of a month or two. And so rare, but we do have it in our Ixodes ticks, and it's really hard to test for. It's one of the pathogens they look for, and this tickcheck.com, which is kind of cool. So I like to know if it's in our environment, but just be aware that other spirochetes can come from the Ixodes bites. And then I'm going to give you a case of Anaplasma and Babesia. The one thing I'm not going to talk about is Powassan virus. I don't know that we have it locally, thankfully, but what I want you to know is Powassan is, it's usually an encephalitis. So what you should do with it in your own head is if you have a category in your brain for West Nile or Eastern Equine or St. Louis or La Crosse, those weird mosquito-borne encephalitides, just remember that there is a tick-borne encephalitis that's just like those. And so if you're ever asking somebody, say you had, saw a patient in the summer who had a meningitis or an encephalitis, and you test them for the mosquito-borne stuff and you strike out, remember there's a tick-borne one too that can come from the Ixodes tick. I don't know that we have it here. I don't know that we know if we have it here. It's certainly it commingles with wherever the Ixodes is though, so we'll probably get it at some point. So any questions so far from anybody? And then again, moderators, please stop me maybe at like 12:50 or something, so we give Jen 20 minutes or 25 minutes or whatever you guys want. I can stop whenever. But I was going to give you a case first of a person I saw about 3 weeks ago. And she was a 74-year-old, really cool lady who had just started on dialysis a couple months ago. And had a couple other comorbidities that ended up not being pertinent. She had a port in her chest for a long time and a new port in her other side of her chest for dialysis. So she had a lot of venous access that was worrisome. And she came in basically with just, I don't feel well. That was her chief complaint. I don't feel well. I'm too weak to really do much. I have really high fevers and she looked ill enough that she was transferred from a small facility to a bigger facility here, but didn't look toxic, didn't look like she was heading to the ICU right away, but definitely looked uncomfortable. Her major review systems was that she hurt all over and she just didn't feel good. Couldn't tell us where her fevers were coming from. She's very febrile, a little bit on the hypotensive side, and really her exam was significant mostly for the absence of focal findings. You didn't have any heart murmur. You didn't have a big findings on lung examination, non-tender belly, et cetera, et cetera. So, and then of course she's got this port and a TCC. So basically 2 large bore venous accesses sticking out of her chest, and imaging didn't show much. So sort of a sourceless fever. And but the labs I want to point you to. So what's going to earn her a particular attention for tick-borne infection are these labs. So now these could be the labs of sepsis, honestly. Sepsis NOS, and she in fact has sepsis, but the pathogen is going to be a tick-borne illness. But if you look at the relatively low white blood cell count, actually significantly low white blood cell count, and low platelets, and then mild transaminase elevations. So sort of looks like most of our hepatitis C patients with liver enzymes. Now it's interesting. Remember, these are acute. How often during our Hep C echoes have we presented a patient with basically that entire CBC and yet they're cirrhotic, right? So it sort of looks like the CBC of a chronic liver disease patient, but it's acute. But this is all acute. So remember, that's almost what a tick-borne panel looks like. They're relatively low white blood cell count, low platelet counts, mild transaminitis, and that's a pattern you have to recognize. That pattern is enough to earn them doxycycline. That right there, I'm sort of done at that point. So what happened? This lady came into the ER, and what was most overt were those 2 large bore venous accesses. So the thought process was, hey, maybe you have a gift of dialysis or your port. So maybe you've got staph or strep or some gram-negative bacteremia from that perspective. She got good gram-positive and gram-negative coverage, and it didn't do anything. So her fevers were unrelenting. I include the social history. Most of us have EMRs, have electronic medical records with a built-in social history that auto imports. And I want to just let you know how particularly useless they are in general for tick-borne illnesses. This was her social history from the imported Epic. You know, there's nothing on here that tells you anything useful from a tick-borne risk perspective. Our nice fellow took a better history. Turns out, you know, she's yes, she's 74, but man, she's killing it. She's out there working in her yard, you know, having daily battles with raccoons and deer to keep them out of her bird feeders and stuff like that. She gets eggs from a friend who has chickens, and but you know, the cool part is she adamantly denied tick or mosquito bites. I thought that was fascinating. You know, she's like, no, I don't have any tick or mosquito bites. I keep an eye out for them. I look for them, but certainly outdoorsy. So what you have to establish with your exposure history is risk. And I'd say that certainly she has risk. So we started her on doxy based upon her CBC and her risk exposure. She got better in about 3 days. She went home, and then, you know, almost a week later, the answer came back as anaplasma was positive. You don't ever want to be starting doxycycline on somebody based upon this test result, because you're going to be 7 days behind. You want to start it on suspicion. So when's the right time to start the doxycycline? It's when you think about the tick-borne illness. Send the test, keep an open differential, but initiate your therapy based upon clinical suspicion, and de-escalate or discontinue the therapy afterwards if it comes out, you know, negative, or you get an alternative answer. But what sort of differential should you keep in your mind for these tick-borne illnesses? This is a wickedly important thought process. What do you need to think about? You need to think about that which can kill your patient immediately, which is meningococcemia or sepsis NOS. So usually that's like strep pneumo or MRSA nowadays. So a wonderful cocktail for a patient like this would be vancomycin for MRSA, ceftriaxone for meningococcemia, and doxycycline for tick-borne illnesses. That would cover all your bases, and then you can sleep on it and order some tests and go from there. But yeah, vanc, ceftriaxone, and doxy is my I'm scared something bad's happening and you came from the community cocktail. You know, textbooks will tell you that your pathologist can identify these intracellular, they're called morula, but there's little intercellular collections. I have yet to see a pathologist correctly identify these. So I'm not sure how often this is useful. But this is a case example of anaplasmosis. There's a near mirror image pathogen called ehrlichiosis that comes from the dog tick. So let that make you paranoid, whether it be a dog tick or a deer tick. You can get these sort of sourceless sepsis microbes. They are in our area. We in the southern half of the state have more Ehrlichia, and in the northern half more have anaplasmosis. And again, they come from different pathogens. It's the anaplasma that comes from the Oxoides tick. These are pathogens of cellular elements. So these are pathogens that parasitize or live in our white blood cells. And as such, they don't claim an organ system, they claim the whole body. And so you get symptoms all over the place. I thought this slide was fascinating because this patient is not what I would classically describe in my own mind as a person who's at risk of a tick-borne disease, and I'm wrong. So if I pull up the CDC and I say, what is the most common age group for presentation for anaplasmosis? She was right there. So apparently it's the elderly. Part of that is probably because as we age, our intracellular defenses decline. That's our T-cell mediated immunity, sort of gets worse with time. Yes, the younger folks are probably getting more tick bites, but the older folks are getting more symptomatic and sick. So just think of this as a disease process that might present in your elderly patients, interestingly enough. Clinical manifestations, all I want you to remember is it's a febrile, non-specific illness. As with any disease process that it really causes a lot of cytokine release, you tend to get headaches, you have lots of muscle aches and pains, you have what seems like a really bad flu-like illness, you can have nausea and vomiting and stuff like that. Seldom do you have a rash. And it can be a disease that can last a month. It can last a while. It can kill you if you're immunocompromised. So you definitely want to recognize it and be aware of it. And again, the labs that are going to key you in are that, you know, I have a febrile patient, but my white count's not 25,000. It's normal or even low. But I do have a little bit of maybe a left shift. So I've got some bands spitting out there, some other stuff that tells me my immune system's activated. My platelets are low and I don't know why, and my liver enzymes are a little bit high. And again, these liver enzymes are not in the thousands like an acute viral hepatitis, but they tend to be in the low 10, like the high double digits or low triple digits. Headaches are predominant. I see a lot of patients get LPs with these tick-borne illnesses, and the LP can be abnormal or normal. If it is abnormal, it tends to be a lymphocyte predominant pleocytosis and so on and so forth. So, and the punchline is this one: you think about these, you treat for them. So you see that pattern, you get a patient in the summertime, or at least a tick-borne season that has that compatible CBC. You can send out your exotic tests with serology and ask for peripheral smears. And in this case, we sent a PCR, but you really want to think, when you think about it, you treat, and then you use clinical response as one of the major cues, as if you got the diagnosis right. Ask me any questions so far on anaplasmosis. I'll probably put it on pause on that one and let Jennifer talk if she's back. Any?
I'm back. That was great.
Oh, thanks. Yeah, and it's true for all these tick-borne illnesses look the same. I promise you cannot tell apart. So basically, I'm like, I don't know. It's one of the tick-borne illnesses, one of those myriad, numerous ones, and you go from there. You think about it. The only one so case 2, and I'll do it in 3 minutes. Is I'm not going to make it a mystery. Exact same HPI. You know, it's another human who just has fevers and flu-like illness in the summertime. They went to the Jersey Pine Barrens and ended up getting labs that looked a little different. So yes, the white count's still low, the transaminases are a little bit abnormal, so nothing unique from that perspective, but they're quite anemic. And so remember, there's this intraerythrocytic parasite called Babesia that can come from the Ixodes tick. Think of it as our locally acquired malaria type syndrome. And we have, by last official count by the CDC, had 0 cases in West Virginia. I forgot to look up Maryland. I apologize, but it tends to be more New England-y, and again, you cannot clinically tell this apart until you get labs that show that the person has a little bit of an anemia that makes you think of the white blood cells. It's just going to be another febrile illness, and it's that hemolytic anemia pattern. And again, the CBC can be their high or low white blood cell count. The platelets tend to be low. So this, again, it fits that tick-borne illness acquisition, but with the addition of a hemolytic anemia. And this is a weird pathogen. It requires weird treatments. It requires AA. So atovaquone's an antimalarial, and azithros are good old Z-Pak. But you have to treat people with that for about 10 days to get them feeling better. But just think about these co-infections when you have somebody that had a tick bite or might have had a tick bite, and say you're treating them for Lyme disease, but they're just not getting better with amoxicillin or cefuroxime or something, anything but doxy, and they have these prototypical CBC, it's enough to think of it. I appreciate y'all's attention. I'm going to turn it over to Jennifer. Any questions?
Dr. Gilfus, this is Dr. Rexrode. Is there any concern for resistance to doxycycline with all of this, we're using it so often for this?
Great question. No, thankfully. Yeah, that's a beautiful question. In fact, doxy's by far and away the drug of choice, the superior choice, definitely for anaplasma and Ehrlichia, and the rickettsial illnesses. And in my opinion, even the spirochetes. I like it above and beyond the beta-lactams. But no, at this point, thank gosh, we're not worried about that yet. Probably because, we are not, as a human population, the reservoir. The reservoir is little mice chilling in the woods, or deer, and not even agricultural animals. So we're not worried about sort of that baseline exposure to tetracyclines. That's the day mice start taking doxy or something, if they get a dermatologist and they start getting doxy, we're in trouble. We'll run into that. But right now, the reservoir is non-human, so we're okay, and non-agricultural, so we're okay. Good question.
Any other questions? I'm just going to help Mitra out. I think she's having some issues still. That is fascinating, though. Dr. Gilfus, I could listen to this a lot. I like bugs and animals too, obviously.
Bugs, cool. Yeah. Every one of those bug categories, they're all weird.
It is really, it used to be worried about it more when you go hiking or, when I was younger, we go camping, but now it's so prevalent that even just taking my dogs just, really close into the grass, they're everywhere. So it's just very prevalent. So this is a really important topic. And I think we'll always continue to want to learn more about it. Anybody else have any questions or comments? All right, well, if you think of any, put them in the chat for us. Thank you so much again, Dr. Gelfus. And Jen, I can just share my screen for you, correct?
Yes, that would be perfect. Yeah, that was great, Dr. Gilfus. Thank you. But incidentally, I had a dog who had tick bite paralysis, and in a matter of hours, she couldn't move her body except for her head. It was really dramatic, and luckily we had a vet who figured it out and she recovered. But I had never heard of it, or had forgotten if I had heard of it before.
Yeah, it's fascinating disease. Always think to look at it if you have a patient that you think might have Guillain-Barré. That's been the times we've found it in the hospital. Is you think someone has Guillain-Barré, but then someone finds a tick somewhere on them.
Right. Anyway, so we'll this is a pivot, quite a pivot from tick-borne illness to hepatitis C. But there are a lot of regulars on the call today, which I'm glad to see. And we the ECHO team has included me in some conversations about what we're calling community echoes. So encouraging those of us who are typically the spokes to take a turn at being the hub and to share something from our practices with respect to whichever clinical echo topic we are on a call for. And so I'm sort of piloting this, I guess you would say, with some conversation, I hope, about hepatitis C. And my credentials are just that I treat hepatitis C here at New River Health Association in Fayette and Nicholas counties. And so we thought we would start this community echo by me just sharing some of what I do, but I'm really interested actually in learning from you all. And so I hope that it will be a conversation for people who are taking care of patients with hepatitis C. When I think about the Hep C issues that are of interest to me as a treating provider, it comes down to screening and treatment, which I'm going to talk about today. Also referral processes for those of us in primary care, how we're getting patients referred to us, and then follow up and monitoring, and what systems. This is about these conversations are about systems. And so I'll over the next several months be talking about each of those topics, but today it's screening and treatment from the spoke practice perspective. Elizabeth, you could go to the next of my 3 slides. So if there were extra credit, I would give extra credit if people can identify in the chat these literary quotes. If you build it, they will come. Where'd that come from, and who wrote it? But I'm going to start by talking about how we screen for hepatitis C at New River, and linked closely to that is who treats for it. So I'm a physician assistant, and I've been at New River Health Association for a number of years. I also spent 7 years as the clinical quality improvement director at the West Virginia Primary Care Association. And you all may not know this, but in 2015, Cabin Creek Health Systems, so Craig Robinson and Amber Christ, the PCA and the CTSI worked to actually bring Project ECHO to West Virginia. It was the vision really of Cabin Creek, and because of the number of people they had in their organization with hepatitis C who they needed to get care for and were struggling. And so they found out about Project Echo and partnered with CTSI, who partnered with the PCA to establish Project Echo in May 2016. And being part of that process, I attended the echoes and started learning about hepatitis C, and then started treating hepatitis C. And in our practice, which we have about, we're an FQHC, we're present in 3 counties. We have about, I don't know, between 15 and 20 providers, a number of sites that do family practice, and a number of school health sites. I'm currently the only medical provider treating hepatitis C in our practice. And I'm going to talk more another time about referral, but I can tell you that my colleagues, once they learned that I was involved with ECHO, which is one way a primary care provider can learn about how to treat hepatitis C, and it's my favorite way. There's also the West Virginia HAMP program led by Dr. Judith Feinberg, which is excellent as well. But my partners have been really good to refer patients to me. So at any rate, that's how we started with in-house treatment for hep C at New River. And I am curious to know, obviously those of you who are on the call are taking care of patients with hepatitis C, but I'm curious, are there other people in your practice who are treating hep C, or have you thought about recruiting other people to treat hep C?
Jen, this is Carmen. We're a smaller practice, and so we have 3 sites in 2 counties, and only 2 physicians right now. And actually, we have not thought about having anybody else treat hep C, just because we don't have the volume.
That makes sense. Anybody else on the call who's treating or whose practice is treating? I saw Dr.
Yep.
Forney.
Please feel free to chat in or just unmute. We'd like that conversation to go. We'll keep going, and thank you, Carmen, for your input. Jen, you're on mute still.
There we go. Dr. Fournier may have dropped off, and I don't see anybody else speaking up. This is so this, if you build it, they will come. This is from, as somebody may know, it is from Field of Dreams by J.P. Kinsella, about the history of a novel about the Chicago Black Sox scandal. And it was also made into a movie with Kevin Costner. And my point with the quote is that we launched into treating hepatitis C with the help of Project Echo, which I love to rave about, because as I told Dr. Aurora, the founder of Project Echo changed my life. It's true, because it's given me the capacity and the ability to treat people with hepatitis C. And lo and behold, once I started getting involved, people started referring patients to me. So, oh, Robin, thank you, Robin. 3 providers at your clinic who are treating hep C. That's awesome. Couldn't get your computer to unmute. Okay, well, I'm glad you chatted in. That's terrific that you guys are all treating. Can you chat in whether, I know that you use Echo. Do those other providers use Echo or HAMP? How do they treat? Echo, beautiful, awesome. Okay, so it's been very encouraging to me to be able to incorporate this into my practice, into our organization and our community. And So I encourage people who are listening who aren't treating to do it, and people who are treating, if you have a larger practice, to consider recruiting another provider. I'm thinking about that only because I can see that I'm over the next maybe 5 years will be winding down my practice. So I think it's starting to get somebody involved is time. Okay, the next slide, which I also think might be my last one. So this quote, if you don't take a temperature, you won't find a fever. I really want to know if anybody knows where that comes from. And it's kind of the inverse of the point that I'm trying to talk about now, and that is screening protocols for hepatitis C. And so at New River, we have several ways in which we try to encourage providers to screen for hepatitis C, along with all the other things that we as providers have to think about screening for. One of the easiest things, we use Athena, EHR, and Athena has a nice quality tab reminder, which is based on the CDC guidelines for hepatitis C screening. And so that allows either the provider or the nurse to work those quality reminders and offer hepatitis screening to people at any point when they show up for a visit. I really like reminders like that, and I think they're helpful for population health. We also have done a lot of in-house education. We have monthly all provider staff meetings. We had Dr. Feinberg come many years ago to talk about hepatitis C and HPV. She's a dynamite presenter. She made a huge impact on our providers, and really encouraging them to screen. And so if you know that your providers aren't screening regularly, I recommend bringing in an outside speaker to educate and encourage. We also do somewhat regular reminders through reminding our staff that I treat. And so that's probably annually, maybe a little more often. I will speak to our providers at a staff meeting. I'm getting ready to do that next month. And I also occasionally send an email to let people know. It's interesting. One thing I've noticed is that when people have been screening more, they are finding hepatitis C, they have a tremendous sense of urgency to get the patient in, and which isn't necessarily the best thing for the patient or the schedule, and isn't often necessary. So one of the things that I'll be talking to people about is the history of hepatitis C, and just letting them know that as long as they get the patient in, there doesn't have to be like a next day thing. They tend to get a little disturbed when they see that it's positive. We have a medication-assisted treatment program here at New River, and that's another place that we are able to screen a population that's obviously quite high risk. Our MAT program inductees have a medical visit prior to or immediately after they start their medication, which is called induction. And at that visit, they are supposed to be getting blood work, including screening for infectious diseases, hepatitis C and HIV. We are part of a quality improvement project through WVU and Yale called the Birch Project, which is looking at MAT, Hep C, and HIV. And as part of that, we recently did a chart review of our patients in our MAT, currently in our MAT program, our people who have less than a year of sobriety. So they're either coming weekly or bi-weekly. And we actually found out that about a third of those people who have been enrolled in our program for anywhere from a month to 11 months had not been screened for hepatitis C or HIV. And so we're getting those people screened and making changes to our patient workflow to ensure that our MAT participants are getting screened timely. One reason to screen them timely is because they sometimes drop out quickly. And so at least we can know if we get them screened within a week or so of when they start in the program, whether or not they have infection and need treatment for that. The good news on that bad news story is that of the people who had been screened, only one was still positive without treatment, and she had just started in the program. So the other two who had been positive were treated. We have a small number of people in our program, so it was a pretty doable project. So I'm curious what practices on the call do to promote screening in their organization, and do you think it's working? There's no, for community health centers, there's a UDS measure for HIV testing, and we know that we're notoriously bad at screening for HIV. There's not an UDS measure for, these are the quality measures that we report to the federal government. There's not one for hepatitis C, but I think it probably parallels. So I'm always looking for ways that we can improve. And so I'll just put it out there. Anybody have a screening strategy that is consistent with what we're doing here, or perhaps something fresh, something new?
Thank you so much, Jen. That's excellent and great feedback, and just really appreciate the kind words about ECHO. And I'm just hoping, everybody feels that way about joining and getting to, take this experience and make you confident in treating your patients. Does anybody have any comments or, how they promote this type of testings?
What do you guys do there at Pendleton, Dr. Exrod?
Well, I'm afraid it's a little sporadic. I mean, we certainly try to go through our quality measures and talk to people, and we're finding people who, a lot of people cooperate when we say, hey, once in your adult life, you need to be screened for HIV and Hep C, and some of them are like, no, I think it just, we try to keep having the conversation. It's about the best we can do.
Do you have an EHR reminder? I'm curious.
We use Athena as well.
Yeah, so that helps, I think. Yeah.
So I was hoping you were going to say you had something brilliant that worked for everybody, and we could.
It's part of why I agreed to present, because I'm hoping everybody else will have something brilliant. Yeah, I think it's just
not I.
Yeah, it's just persisting with it. I think the EHR reminder is the closest thing to brilliant you can get.
Jennifer, can I ask you a question? How do you remind your group once a year that you treat Hep C? How do you get that word out there?
We have a medical staff meeting monthly, and for example, recently I decided that it was time for me to, so my CMO has me on the agenda for next month, and I'll remind them, and I don't have numbers to back this up, but I can tell you that the last time I spoke to them, which might have been a year ago, I started getting lots of in-house referrals, and I've done chart reviews on our practice for peer quality review, whatever that's called. And I think my partners do a pretty good job, actually, of routine screening. But I noticed after I spoke to them at a meeting, they started referring to it. And I think they're relieved. What they tell me is, oh, thank goodness we have somebody we can send patients to, that we don't have to wait for GI or ID to have an opening. And so I think once it's in their head, then they're relieved, and that may help them to remember to screen too. I don't know, Dr. Rexroad, do you think that's your experience?
I think that's fair. Yeah. I mean, we talk about it, and there again, we're a smaller group with fewer sites, and I actually go to each of the satellite sites on a regular basis. So, Yeah, and I've actually treated people at all three sites now. So, it's word of mouth really through the practice. We don't have a formal reminder system, but we try to talk about it.
Right, yeah,
And I've got a nurse who's, become very good at, all the paperwork parts of it. And that helps a lot too. I think she gets questions from other sites. And so, we've tried to kind of make it a little specialty within the practice, but.
yeah. The other thing is I occasionally, also probably once a year, send out an email. And a lot of times that's to thank people for referrals and to give them a little bit of follow-up about maybe other things they could do, like they could order an ultrasound or they could order these labs, or sometimes there's a reason that I want to give them a little bit of feedback, and that also keeps that in the forefront of their mind.
Yeah, I think just keeping the conversation going within the practice is, and that serves as a reminder to do the screenings as well.
Right. Yeah, exactly.
Because, I think the thought has been, well, what are we going to do about this, or who are we going to refer them to? And I've actually, I think because of this echo, inherited a couple of HIV patients who were stable and who were traveling long distances to try to get their care. And it's like, this is ridiculous. I can do their maintenance, and if questions come up, I know now who to ask.
Right. Yeah, exactly. It's so exciting. Which brings me back. So this is a nice closing the circle, as they say, to if you don't take a temperature, you won't find a fever. So that's from The House of God.
I know.
And I always remember that, which is a novel. If you haven't read it, it's a satirical novel from way long ago about residency. And it's actually about how to get out of doing more work. But in this case, we know if you're not screening for Hep C or HIV, then you're not finding it. So.
Excellent. Nice closing. I like that loop, Jen. I do wonder, I know we just have a minute, but what is the pushback? I feel like I'm the opposite. I push for more testing. Like if you could just do everything, I'd be all about it if it was free. That's what's usually holding me back. But why do you think people push back saying no to testing for HIV and Hep C?
It seems clear to me that it's stigma. I made the mistake one time of testing somebody for HIV and Hep C either without getting her permission or without documenting that I got her permission. And she was mortally offended and transferred care. And she and her family lodged a complaint against me. And so that's not my typical practice. I usually like to discuss it with people, and I have a good way of encouraging people to get it, which is to just be plain about it. But it was clear to me that they were offended that I would think that she would have a risk factor.
Oh my gosh, that's so interesting.
I think that's my experience.
Yeah, I didn't know if it was like, yeah, that makes sense. I thought it was that, or some people just would rather not know, kind of like the temperature thing. Like if I don't do like no, then I don't know.
Good point. I see that more with other things like cancer. There may, in some cases, I think it also comes down to at times to money.